Hello, myself Dr. Maneesh Jain. Presently, I am working as an associate professor in Department of Medicine, Bundelkhand Medical College, Sagar. Today, we discuss the newly diagnosed type 2 diabetes with high baseline HbA1c level. One of the 45-year-old patient with a newly diagnosis with type 2 diabetes visited clinic 6 months back with multiple risk factors like obesity, hypertension, dyslipidemia. He was initiated with a metformin with advice for lifestyle and diet modification. Recently, he visited again as a part of the routine checkup, his laboratory workup, and so following reports. HbA1c is 8.5, GFR is 80 ml, LDL is 80, HDL is the 38, and triglycerides is the 200 milligram per deciliter. Patient is present on medication like metformin 100 mg, 1000 mc MDPID, lisinopril 40 mg, metoprolol 100 mg, and atorvastatin 40 mg, along with aspirin 75 mg. His physical examination is BMI is the 31 kilogram per meter square, and blood pressure is the 120/70, and present heart rate is the 78 per minute. Evidence indicate that early intervention and achievement of the glycemic control reduce the long-term risk of microvascular and macrovascular complication of type 2 diabetes mellitus. One of the UK PDS trial that so. UK PDS demonstrated legacy effect of the early intensive therapy because the difference in the CV event rate 10-year post trial was apparently even through no difference in HbA1c level between the intensive and conventional therapy. When metformin is the not suitable, at empagliflozin or linagliptin is being considered as an alternative first-line treatment. Initially, combination therapy may be considered to achieve target more quickly, particularly in the patient with a high baseline HbA1c level. Early combination therapy in the type 2 diabetes make a clinical sense for several reasons. First, the reason for the early initiation of combination therapy is the meta-analysis demonstrated the early use of the combination therapy significantly increased the likelihood of achieving the glycemic target HbA1c less than 7 compared with the metformin monotherapy. For patient with HbA1c more than 1.5 above goal at diagnosis, AD and ESG guidelines also recommend first-line treatment with a dual combination and a SGLT2 inhibitor as a first post metformin treatment in patient with established CVD, CHF, or CKD. The summary of the this case study is the EMPA and LINA combination with complementary mechanism or pleiotropic benefit may be suitable option across the range of the patient, including those with established atherosclerotic risk marker or high risk established heart failure or CKD due to tolerability of the combination in addition to the potential benefit of the empagliflozin on cardiovascular and renal outcome, and no increased risk of the heart failure with either agent. According to a study, early achievement of the HbA1c goal less than 7 with Empalina could reach target HbA1c at the 12 week compared to monotherapy. HbA1c decremental by Empalina has demonstrated 1.8 HbA1c reduction at HbA1c baseline at 24 weeks in metformin target group. The benefit of glycemic control were maintained at week 52 in the metformin treated group, and the higher percentage of the patient achieving HbA1c less than 7 were reported for combination. The combination offers a suitable component in the strategy to achieve target HbA1c without increased risk of the hypoglycemia and weight gain, with the improvement in overall lipid profile. A reduction in the incidence of the genital infection associated with the SGLT2 have been reported where a DP4I added, perhaps because of a better glycemic control, although the possible mechanism remain to be investigated. And last, some of the this case study, empagliflozin linagliptin combination provides robust HbA1c reduction in and 2 to 4 times higher order of patient reaching the goal HbA1c compared to the individual treated with low hypoglycemic risk. Thank you.